Good morning, everyone.
Good morning. Hi.
How are you doing? It is bright and sunny out there in Southern California, isn't it? Don't we love it? Oh, wait a second. Wait a second. I've got a ringer here. I can't believe it. How you doing, Donna? It's good to see you. We have another one of our faculty members here, by the way, Donna Stahl. She's a faculty member in the Master's of Health Administration program. She's one of our top teachers. We always love to see her. And so my name is Mike Nichol. As we were introduced by Dean Knott, my background is in health policy. My interests are predominantly within the field of cost effectiveness as it's applied to healthcare, and that includes measurement of cost and also measurement of preferences. I do a fair amount of work related to longitudinal data analyses and how people's past behavior predicts their future behavior. So I'm very much interested in a lot of the topics around healthcare reform and how health administration in particular can contribute to us providing better care at hopefully a lower cost, or at least a lower increasing cost, which is probably the more relevant piece. Darius Lakdawalla is a new faculty member who's joined us, and he's going to be talking a little bit about some of the issues around payment. But I thought what I would do first is kind of frame some of these issues about healthcare reform, particularly within the context of, what's the nature of the problem, and why are we having difficulty coming to some kind of a resolution around health reform, and then just give you a little bit of an idea about the complexity associated with some of the reform proposals and why those proposals are so complex. Now, I could put up a chart that shows what's going on with regard to healthcare cost. Anybody surprised about what's going on with healthcare cost? No, it's outstripping inflation. And anybody want to venture a guess as to why it's outstripping inflation?
Medical procedures are more complex.
Medical procedures are more complex. We have new technologies that are being applied. Our society is probably the most adopting of new technologies in the world as it relates to healthcare. Another one.
We're funding more people that don't pay.
We're funding more people that don't pay. We're funding a little bit more people that don't pay, but by and large, what's going on also is that we're getting demographic changes. Guess what? Us baby boomers are getting older. Unfortunately, what happens when you get older is the wheels fall off on healthcare. Okay. I wish it were something different, but unfortunately, as we get older, we start to get all of these additional diseases. Now, the beauty of that is that our age is extending because we're really quite effective in a lot of healthcare-related innovations. It used to be that people that were born in 1950 had the likely length of life that would be approaching about 70 to 72 years of age. The present cohort now has every reason to believe that they're going to have an average length of life of about 82 years. Now, that's a dramatic change within a very short period of time. Some of that is due to the new technology. Now, the issue about we got a bunch of people that aren't paying for the services that they need is a really important issue. And this chart right here gives you a pretty good insight into that. As we start to think about who's paying for health care, a lot of times we've got misconceptions. As you can see with this, approximately 27% here is either Medicaid or Medicare. It's public care that is providing. One of the things that healthcare analysts love to see is that YouTube thing where the person stands up in one of these types of public forums and says, "We've got to get government out of healthcare. I love my Medicare." Excuse me. You love government in healthcare. So government has a profound impact on healthcare. There's no question about it. We're still dealing with about half of all of the coverage occurring through employer-sponsored care. That occurred sometime around the end of World War II when we had situations where people were not able to get additional wages, and so employers came up with the idea that they'd provide an additional benefit, and that was healthcare. So you can see that we've got a significant portion of the funding related to health coming from employers and coming from the government sector, both state and federal. The uninsured represents about 15% of 300 million people. That's a lot. And that's one of the motivations that we have within the health reform movement. a need to be able to have access, and also the need to incorporate them from the standpoint of the community insurance pool. Why do we have insurance? What's the whole justification for insurance? Why do you have home insurance?
Spread the risk.
Spread the risk associated with events that we can't predict, right? We don't know who's going to get sick. We don't know who's going to respond to treatment. We have risk associated with both the event and then also the consequences associated with the treatment. So we've got some considerable issues here with regard to access. We've got some considerable issues with regard to the foundation that we have for funding healthcare as well. Now, one of the things that I thought would be useful is for us to think a little bit about some of the concerns that we have. Oh, not that one. Hang on. Okay. There is a terrific website, by the way, if you are interested in getting additional information about healthcare, both the funding and also some of the different things that are going on with reform. The Kaiser Family Foundation, kff.org, provides very good, up-to-the-minute information. And a lot of the analysts go to this to just give you a little bit of additional information. As you can see on this one, they've got a side-by-side comparison of the major proposals that are out there with regard to healthcare reform, including President Obama's proposal, which he dropped on them a couple, 3 days ago. So we can essentially go in and make comparisons among the House bill, the Senate bill, and President Obama around all of the issues that we see here below. Now, who's concerned about healthcare? What are the actors in the healthcare delivery system? Doctors, hospitals, pharmacy, insurance companies. Are you concerned? Yeah. Taxpayers and patients? Political parties? Employers? State government concerned? Oh, you bet state government's concerned. We haven't talked about nursing homes either. Are nursing homes concerned? Nursing homes are concerned. Insurance regulation. Insurance regulators in the states, they're concerned. Really quickly, we've identified 10 major groups that are very much concerned about this whole process. And the interesting part is that all of those groups are interacting at different levels, federal level, state level, and where is all healthcare delivered? Local level. Okay, so we've got a very complex process of actors that are interested across multiple areas. Is it any surprise that it's difficult for us to come up with a solution to the dilemmas that are really driving a lot of the healthcare issues, both cost and quality? As you can see, look at the complexity of the different options that they're comparing here. We go all the way from benefit design and financing, prevention and wellness, individual mandates, employer requirements, premiums and cost-sharing subsidies to individuals. If you pull up this particular comparison, you will see within each one of them. Let's just pick one of them here. One of my favorites here, if they'll do it for us. Come on now. Okay, so this is just looking at it from the standpoint of cost containment. You notice how we're getting more and more components. One of the areas that I'd like to highlight here is restructure payments to Medicare Advantage plans. Why are we concerned about Medicare Advantage plans? Well, we're concerned about Medicare Advantage plans because they are one of the primary managed care options for people within Medicare. And during the Part D enactment, which occurred in 2006, that particular bill provided both retroactive payments to insurance companies into Medicare Advantage plans, as well as improved premiums on Medicare Advantage plans, much higher than regular Medicare. So consequently, as we start to look through all of these different cost containment options, it becomes exceptionally complicated. Who cares about the Medicare Advantage plans? Well, the Medicare individuals who have taken advantage of them, clearly. The insurance companies, because Medicare Advantage plans actually provide a good portion of profit for them. And the providers who are actually part of those Medicare Advantage plans. That's just one of the components around cost containment. So it's not surprising that we've got a level of complexity here that makes it very difficult for us to come up with a reform plan that can be easily adopted. The one thing that I would recommend that you do too, there was a study, it was actually on the Kaiser Family Foundation, funded it, looking at the individual provisions of the reform plans. What portion of the population liked virtually all of the provisions, individual provisions associated with health reform? Got any ideas? Was it 20%, 30%, 40%, 50%? I think it's lower than that, don't you? About 60% of the population liked each of the individual components. Now, what proportion liked the whole reform bill as a total? About 40%. So we like what's going on with it, but we don't necessarily like the whole package. All right, with that, set it up from the standpoint of some of the issues that are the complexity surrounding this. I'd like to move it over to Darius, let him introduce himself and talk a little bit about some of the issues that are really driving some of the reform areas.
Thanks, Mike. I always, whenever I talk about the policy issues, I like to start out with a comment that was once made by Douglas Holt-Eakin, who was one of the key economic officials of the Bush administration. He used to like to say, Social Security is like Grenada, but Medicare is like Vietnam. And by that, I think he meant if you got a bunch of people in a room for 3 weeks and asked them to solve what ails the Social Security system, we could probably do it. We could ensure the solvency of the system, ensure everybody gets paid, and generally improve the quality of the system. But with Medicare, hopes do not flow so freely because there are a lot of more fundamental issues. And as you might have expected from my dismal introduction, I'm an economist. I'm a health economist in particular. I just started at USC in the fall. I'm very happy to be here. I was at the RAND Corporation for 9 years prior to that. A lot of my research is on risky behavior, insurance, and also on pricing and sort of the firm-level behavior in healthcare markets. So what I thought I'd talk a little bit about today was this issue of why this is such a problem, why Medicare is Vietnam and whereas Social Security is Grenada. Because even Social Security, it's a fairly large problem, but it's not nearly as thorny as the medical care problem. And I think it really boils down to a couple of simple facts about the healthcare system. The first set of facts is that nobody wants to receive cheap healthcare, but nobody wants to pay for expensive healthcare. So that's kind of one part of the problem. But that being, one could say that for just about anything. You could say that people would like to drive expensive cars without making payments. People would like to go to fancy restaurants without picking up the tab. So what's really different about the healthcare marketplace that you don't see in cars and restaurants, for example? Well, it's really because there's a whole lot of central planning in the healthcare market that is not present in other industries in the United States. I mean, a lot of people are concerned about the advent of national healthcare and single-payer systems. I don't know if we have single-payer systems today, but we certainly have a pretty national healthcare system, or a pretty much national healthcare system. As Mike put up some figures on where insurance comes from, so about 30% of Americans get their coverage from the state, from the state or federal government. But if you look at expenditures, it's actually even higher than that. About 40 to 50% of healthcare dollars come directly from the federal or state governments. The number's higher if you want to count things like tax subsidies for insurance and tax subsidies for development of new technology, that kind of thing. So really the system in the United States is a mixed system, but there's a huge public component. And now whenever there's a huge public component to a marketplace, the government likes to think it can just kind of name a price and name whatever price it likes to pay and kind of not face any repercussions. But of course, that's not the case, and it's not the case that the government can simply choose what payments to set, or we as taxpayers can choose what payments to set without facing consequences. There's a very kind of well-defined relationship between the prices that we kind of choose to pay and the quality of health care we end up getting. So, for example, there's a lot of evidence suggesting that if we go about cutting reimbursements to doctors and hospitals, as has been proposed through the Medicare system, it's pretty likely that doctors will work less, work fewer hours, that will attract different kinds of people into the medical profession, that hospitals will invest less in technology. There's also a lot of evidence that if we cut drug prices, that pharmaceutical companies, of course, they're in it for the money that they make. So the less money they make, the less effort they're going to devote towards new discoveries. So there's this fundamental tension in the healthcare system that's not easy to resolve. We can charge low prices and make sure everybody gets the care they need, which is clearly a goal that we can all get behind. But the problem is that low prices also compromise the quality of care that everybody ends up receiving. So there's this fundamental tension between prices and quality that has to be resolved. And that's really the reason why it's not such a simple issue, that we can't just all sit down in a room and say, let's ensure that everybody pays low prices and gets great quality care. That's not going to happen very easily. Now that being said, there are a number of sort of glimmers of hope on how that tension might be resolved. Glimmers, not necessarily rays of sunshine, but a few glimmers of hope on how that might be resolved. For example, Medicare Part D was the prescription drug benefit introduced several years ago in the Medicare system. As these things go, it's not a huge program. It doesn't cover that many Americans in the grand scheme of things. But the way it approached this problem was a little bit unique and sort of hopeful in a sense. And the way the Medicare Part D benefit is structured, the basic idea is that let's ensure that people face lower co-payments for their prescription drugs. That's one part of it. Okay? Lower, I don't know about low, but lower than they were facing before. So they get better access to the medications they need. But at the same time, let's also ensure that we don't see substantial declines in the prices that manufacturers receive for their products. And so in addition to promoting access to life-saving therapies for patients, there was also an effort made to ensure that profits or incentives of manufacturers to come up with new drugs weren't substantially damaged. So Part D succeeded in that goal, really. There are lots more people who take the medications that they need to take. There's better compliance with their therapies today than there used to be. There are better outcomes among patients enrolled in Part D compared to uninsured patients in the elderly population. And there wasn't a huge impact at all on the rates of new drug discoveries. So we saw in this case there is a way to balance the competing demands of price and quality, but it's not an easy thing to do. Part D arose and it was kind of hammered into a relatively small program because there were a lot of people who were compromised by the way the Part D legislation ultimately came out. Manufacturers always want ever higher prices. Patients always want ever lower prices. So it's hard to come to those compromises. But really, to get to the heart of health reform and get to the bottom of solving the healthcare crisis, it comes down to that kind of an approach. You've got to get everybody in a room and ask yourself the question, how can we ensure that patients have access to medications without substantially harming the quality of medications? Or more generally, how can people have access to health care while at the same time guaranteeing the quality of that health care? There are ways to do it, but it requires a lot of realism, and we need to avoid kind of the tempting solution, which is let's just cut prices and cut prices. That's certainly a way to drive down health care costs, no question about that, and everybody's worried about health care costs. But we have to take a longer run view of this and make sure that not only are we paying a reasonable amount for health care, but we're actually getting something valuable in return. It's not just a cost, it's an investment, really. I mean, health is a valuable good, and we need to keep investing in it. And in order to keep all those things in mind, that's a tall order, but it can be done, I think, as Part D showed and some other types of healthcare legislation showed. And so I think that would be a way forward. Perhaps now I think the best thing is to, I'm sure you have a lot of questions about what you've read in the paper and what you've discussed in your circles. Mike and I are happy to take questions.
Don't be shy.
Question?
I have a question. I noticed that on the news they mentioned that they were going to have a 25% cut of payment to doctors for Medicare, and the implications that seems to bring up for patient care. Can you address that?
That is a very important issue because there's already evidence that what's happening is that there are physicians that won't accept new Medicare patients because the payment's not adequate. What you're also seeing, though, is that also extends into other kind of insurance systems. Have any of you heard about Concierge Care? Yeah. And in that situation, what's happening is a doctor says, I'm not going to take insurance, but if you'll pay me a set rate, we'll make sure that you get the best possible care. That's a very expensive option for people, and they may want to do that because they feel that it's important. The trade-off on the reimbursement and the access is a really critical question. Have you seen any of the stats on that, what the impact is?
Well, I mean, I think one thing that is clear about the Medicare system is that the prices are not set with a great deal of, let's say, rationality. And the issue is not so much that prices are high or low or in between. The issue is that all the variation in pricing in the Medicare system is just set up by a bunch of people sitting around a table figuring out what that ought to be. And it doesn't really have much correspondence with what costs or incentives ought to be. And so I think the issue of kind of cutting prices sort of misses what's really going on with the Medicare system is that there needs to be some way of tying reimbursement, the way reimbursement varies across procedures, varies across geography, tying that to real conditions as opposed to just numbers that we pull out of the air. And if you just were to cut reimbursements, a lot of the evidence suggests that the immediate impact would be a decrease in physician work hours. That there would be physicians would be less likely to put in long hours seeing patients, doing paperwork, etc. The long-run impact, which is a lot harder to measure, but I think is the bigger impact ultimately, is that you change fundamentally the dynamics of who wants to enter the medical profession. Right? So for a long time, the returns to being an investment banker were massive, and so we got really great investment bankers and not so great, perhaps, legislators. So the reverse might happen if you got very high rates of return in other sectors besides the medical care system. You're going to get different kinds of people coming in, and that really will affect the way people get care.
So let it be shown that Darius is arguing that we ought to be paying our legislators more.
Exactly. Yes?
What countries in the world are considered the most successful healthcare programs? And is the political stalemate in the U.S. going to prohibit us from moving towards those more successful countries?
That is such a controversial area because when we start to look at success, how do we measure it?
I don't know. I'm asking you.
And there's been a lot of discussion about we don't do as well as some of these other developed countries on particular indicators. But what's important to remember is those are indicators. They're not measuring health. They're measuring particular elements of health.
So we might have a very successful program already in place?
My view of health, I'd be interested to hear Darius' perspective, but the fact that we've actually had significant increase in the expected length of life tells me that we're really pretty successful on the health side of things, particularly given the kind of, I put it within the framework of the kind of stress that we experience within the United States. Many of the countries that are developed provide fewer working hours per week. They provide more vacations. Americans, by and large, still are the most productive population in the country. We work long hours, we work hard, and that contributes to some of the problems that we see within the health environment. So I think that it's just important for us to put that kind of context around what constitutes successful. Okay. There are a number of countries that spend less on healthcare, and there was an interesting PBS show not too long ago, a Frontline show, where one of the reporters went to different healthcare systems around the world. And I was struck by one of the stops that they made in Japan. And they were talking about MRIs, an imaging system that you're all familiar with. And they said, well, now, you're only charging $40 for an MRI. How can you charge $40 for something that in the United States is going to cost you $1,200? He says, because we don't use the most recent generation of MRI. This is actually the 4th generation back MRI. Now, what we've got with the newer generation on MRI is an increasingly fine granularity on the image that allows people to diagnose things that they wouldn't otherwise be able to diagnose. What's the value of that? Well, I can tell you from a cost-effectiveness standpoint, but that's the kind of distinction that we draw across those different kinds of societies.
But the only thing I wanted to add was, one thing I always, it gets a rise out of me actually, is when there's a lot of this discussion in the press about how we get less for when we spend more, and that people cite the longevity numbers. The thing that's kind of patently misleading about that type of argument is, if you were to array all of the factors that affect expected lifespan in every country, medical care will probably be no better than 5th or 6th on the list.
Yeah.
And it's a distant 5th or 6th. Yet it's kind of implicated, the implication that people draw from those variations, which really have a lot more to do with things like socioeconomic inequality, the way education is distributed, behaviors like obesity and smoking, all of those things have much bigger impacts. It really has less to do with getting less for our healthcare dollars and more to do with other aspects of lifestyle and social institutions.
Thank you.
Other comments? Yes.
The cost of healthcare keeps growing as a percentage of our GDP, right? It's up to around 18%. And it's got to stop at some point. We just can't go to 30%. That's ridiculous.
Mm-hmm.
And I just wonder, what do you see as finally breaking it? Is it going to be 25%? It's got to stop somehow. If Congress can't get together, then it'll just keep rising.
Well, I think what you're seeing right now in terms of the motivation around trying to restrict the cost, it's interesting that the president's been framing this within the context of productivity, which I think is the right way to do it. Money spent on this does not allow us to invest in other areas. And that's a great way for us to be able to frame it. What's happening then is that employers are increasingly motivated around this because they see a much larger proportion of the kind of compensation they can provide coming in benefits. USC is very much concerned about that. I serve on the USC Benefits Committee, and we're increasingly concerned that the proportion available for benefits keeps on shrinking, except within the context of healthcare. Obviously, that's another issue that people generally don't see, and I'd like Darius to comment on that. One of my perspectives is because the cost is not considered as we think about our premium dollars, we're only concerned about cost when we actually access the service. And it gets back to the point that he made that when we need to access it, we want the best possible care, but we don't want to pay for it.
And it's about, healthcare is about value, ultimately, and that means that we want to get it efficiently, but we also want to get something for it. And it is true that it is going to be interesting to see where that number eventually comes to rest, because you're right, we can't have 75% of the GDP going to healthcare. The GAO, for example, the Congressional Budget Office and the GAO, which forecast these things for the government, they build in these projections that just kind of assume, it's going to stop at like 40% because they just pull the number out of a hat because everybody recognizes it can't get too high. But there is one other point that I think is not made often enough, which is it kind of makes sense that healthcare is more important today than it was before. It's not going to get to 50%, but it makes sense that it's a bigger fraction of GDP. And the reason is that as everybody gets richer in a society like the United States, what becomes increasingly valuable and scarce is time, because you want time to enjoy the material progress that has been made in a rich society. And health is really about producing time. It's about producing time to enjoy all the things that the society has produced. So it does make sense that people will spend more on health, but it doesn't make sense that it will become 90% of the American economy.
I have a question, maybe it's basic or a small strategy, but let's say on your pie you had the 5% that were private group.
Mm-hmm.
So those are people that maybe have their own businesses, they're paying private insurance, correct?
Mm-hmm.
And they're also contributing to Medicare, as I understand it, on taxes. So these people become 65. What happens to these people? They just continue to pay the private insurance? And what would those 5% do? How does that big pie affect the little 5%?
That's a good question. The 5%, what we're talking about is the kind of uninsured. Let's get that back up.
It was the.
No, it's
The
the
private non-group.
It's the private
right.
non-group.
Yeah, so these guys usually are, well, okay, so who are the uninsured is a good question. And the answer to that is many of the uninsured are young and healthy people who think they don't need coverage. There are some sicker people in the uninsured population. But many of the sickest people in the uninsured population who say don't have access to employer coverage end up in that bin.
But does that also cover people who are just paying their own private medical because they don't have an employer-sponsored insurance and they're not on Medicaid?
Well, these are the people in the retail insurance market. So that means that they go out and buy a Blue Cross policy on their own because they don't have it through their employer.
And did you see just recently, there's been a lot in the news about that, where there have been very rapid increases, 39% proposed
Yes,
increase.
that's what I'm concerned about,
That's that
because
group there.
Actually, my husband and I we both have our own private business, so we don't have employer-sponsored insurance. We have to pay our own private insurance, plus we contribute to Medicare, right? And all these other people can use it for taxes. And then what happens, how does that larger pie affect somebody in that private group that's just paying?
Well, one of the reform provisions is the insurance pools, which would provide an opportunity for both the uninsured to be able to access those kinds of policies, as well as those individuals that are in the private non-group who are essentially paying a very high rate because there is no community experience associated with that. It's your individual experience.
Yes.
I mean, the real problem with one of the problems with the way the system is set up now is that there's this huge tax incentive for firms to offer health insurance, and so there's a lot of coverage through the group market. But of course, not everybody is able to take advantage of that for a number of reasons. And so the people who are outside of that kind of big bucket of people end up in this really select sample, and it's hard for insurers to spread risk in that smaller sample. They face a lot more uncertainty about how to write those policies, and so the result is that group is really put in a bad position by the role of employer-based insurance in the system.
And also, this whole issue about community-based versus industry-based or versus individual firm-based insurance is really critical. And again, because I'm involved in the USC benefit structure, USC, with one of our insurance companies, went away from the community pool, and we were now rated as an individual employer. We're the largest private employer in Los Angeles County. You know, a lot of people don't realize that. So you would think that we've got an adequate pool for one of our insurers who actually captures about 40% of the population, so 40% of the faculty and staff that are here as employees. Our costs increased approximately 40% over a 3-year time period within that particular insurer. Guess what? We had a couple of bad experiences. Someone who needed extreme care, one of those cases that just happens every once in a while, well, 2 or 3 of them happened within the space of a couple of years when we went from a community insurance risk to the individual company. So that is a really critical element for us to consider as we start thinking about it within the context of insurance. Other issues? Yes?
On the insurance side, they are talking about being able to go across state lines. What kind of impact does that have? And why do we have it just within the state? Now, why is the present situation, why does it exist?
When I was talking before about the different levels of control, we have federal control, like Darius is talking about the Medicare payment. Medicaid is shared with state and federal. But the actual regulation of insurance...
I'm talking about the insurance provider.
Yes, but the regulation of insurance occurs within each state. Okay, it is not a federal regulatory environment. And that's one of the things that they're proposing as a way to maybe infuse some additional competition to allow there to be a broader set of plans available that might cut across some of the states.
Yeah, so one of the arguments made for promoting, the original reason for state-level regulation was just a federalism reason. The idea was that states have different economies, they have different interests, and so they ought to be able to regulate the insurance industries differently. On the other side is the notion that when you have a national marketplace, it's going to be more competitive from the point of view of a smaller state, or maybe it's not profitable for as many insurers to enter, set up shop, deal with the state-level regulators. And so promoting competition in the smaller states is kind of on the other side of that equation.
Now, the interesting issue is, as Darius said, we had states that developed their own insurance regulation framework. California has a large number of mandates that are required of health insurers within the state. California was one of the first states to require mental health benefit within your health insurance. And so one of the complexities, one of the advantages might be that you end up with a basic level plan that might cut across all 50 states. But what you may lose would be some of the, those types of mandates. It would require, though, us to understand better what the cost structures are around those types of mandates, which we think would be a really good idea. I spoke for Darius on that one, I suppose I should. Yes, Dean Knott.
My wife is from the UK, and one of the things that I've learned from comparing the two systems, but also Japan and some other systems, that it is true that there are a lot of other social factors that affect longevity, et cetera, but they tend to spend they spend their health dollars differently than we do in the United States. They spend a lot more on primary care, on community clinics, things like this, and less on end-of-life high technologies. Is that something that you think is important in terms of health outcomes? Is that something that we should be looking to do in any way here? And is that what allows them to cover everybody in the population when we are not able to?
No, I think that really goes into a political or ethical arena. Because if we were to ask ourselves the following question, if we wanted to allocate dollars so as to maximize expected lifespan, we could do that. We can certainly figure out ways to do that in the United States. And moreover, the way we do it today is not that way. It's not to, if you want to just maximize lifespan, you should spend lots and lots of money on people who are very young and much less money on people who are old. It's just kind of simple arithmetic. In order, if that's really kind of the goal. It's sort of a utilitarian goal. But on the other hand, it's not so easy, and the UK kind of takes that position. In fact, if you talk to UK regulators about things like end-of-life care, and you say to them, well, there are all these new cancer therapies, and it's true that they might prolong life by 6 months, but a cancer patient might be willing to pay lots of money to, say, see next Christmas. One more Christmas with their grandchild would be worth potentially a lot of money. So why shouldn't you then let that treatment go through? And they'll always say to you, well, I'm not necessarily just worried about the cancer patient. I'm also worried about babies in Manchester. That's kind of the standard response you get from the National Institute for Excellence in Healthcare in the UK. And it's, I think, a really good way of encapsulating the trade-off. They're worried about generating the most longevity in these young populations, and it has to come at the expense of older people. I'm not so sure that's a strategy that would be politically tolerable in the U.S., to be honest. Maybe it would be, but I think that the issue is political rather than, say, economic.
Let me just also finish that up by recognizing that in both Canada and England, there have been new insurance packages that have been developed, essentially supplementary insurance packages, so that you end up with an explicit two-tiered system. Those individuals that are covered by the basic insurance system that Dean Knott's talking about, and then they have the opportunity to purchase more that might expand the types of services that are available and where those services are available. Well, I think the conclusion is that we do have a complex healthcare system, that the pressure is increasing, that there are some options associated with it that may be able to maintain quality and reduce the rate of increase on healthcare costs. So that's the type of stuff we like to do at the School of Policy Planning and Development, at the Schaefer Center, and also in our graduate programs. So thank you all very much.
Thank you.